Okay, so in this section, I'm going to go over the evaluation of pain syndromes. We're not getting into treatment yet. That'll be the next session, but just how to evaluate, how to work up, how to determine what kind of patterns are involved with their pain, whether sensitization is taking place, whether they have a complex regional pain syndrome, and all the different things that can trigger amplifying of nociceptors. So we're right here in the clinical evaluation of pain syndromes. The academic objective of this presentation is to understand physiological mechanisms that lead to exaggerated pain perception and chronic pain, and learn how to clinically evaluate mechanisms that impact pain. So remember the four main concepts of pain. Number one, the perception of pain is brain-based. Pain does not equal the amount of tissue damage. Many physiological and psychological variables impact pain perception. And chronic pain is due to activation of pain pathways, lack of activation of pain inhibitory pathways, or both, right? So those are the main concepts that we went over. Now this is the anchor slide. I'm going to go through each of these line by line, make sure that you're familiar with each of these concepts, and as we go through the evaluation. So let's just start with pain scales. So, remember pain, it's really hard to objectify, and some people even consider pain an emotion, not really a true sense. And when you're looking at having some way to communicate with your patient, there's different types of pain scales that are done. So you have visual analog scales where they have no pain, they kind of draw a line of where they are. Then there's graphic ratings of scale from mild, moderate to severe, and no pain to pain as bad as it could possibly be, and then just numeric numbers like 1 to 10, right? So those are the basic concepts. So either visual analog, graphic scale, numeric rating scale. And then there's lots of different pain scales out there. This is the Defense and Veterans Pain Rating Scale. They even put pictures of happy to unhappy with a degree of pain, and green to red to help, have the person quantify the amount of pain they're suffering. These numeric pain scales are pretty straightforward, but even every time you ask a patient, what percent improvement are you with your pain syndrome? 10%, 20%, 30%. Those are all, grading pain. And then there's also the Mann-Kiske pain scale, which is commonly accepted. So 0 is no pain, and then 10 is unconscious pain that makes you pass out. And then you can have the patient look at this and say, okay, based on this scale, where are you, right? And this is kind of extreme because most people are not. No one's going to really be at 10 that's coming into your office, or 9. So you're going to have a lot of people just kind of in 3, 4, or 5s. But it is a standardized scale that everyone else can agree with and understand when it comes to defining pain. So those are what's out there for ways to objectify the amount of pain that they're having. So remember that pain really cannot be objectively evaluated. These are just attempts to do so, and the description of pain really involves cognitive function too. So trying to use some kind of these pain scales with people that are highly emotional and suffering from pain isn't very effective. Using these pain scales with people that have cognitive decline, like early dementia, doesn't work well. You have it with children. It's very hard for children to kind of tell you where they are suffering with pain with these pain scales depending on their age. So there are some limitations with those. Now, once we move on from from pain scales, let's get into pain conditions. And for the most part, you can break down pain conditions to there is an actual active nociceptor stimuli. Something is actually activating nociceptors. So that could be an inflammatory condition like inflammatory bowel disease or endometriosis or chronic inflammatory respiratory syndrome. It could be a degenerative joint condition like osteoarthritis or degenerative disc disease. It could be an autoimmune condition that leads to pain like rheumatoid arthritis or Crohn's disease or autoimmune neuropathy. It could be a musculoskeletal condition like a torn knee meniscus or rotator cuff tear. It could be a vascular condition like migraines or peripheral vascular disease, or it could be a metabolic condition like diabetes or kidney disease. So these are all pain conditions that have active nociception stimuli happening to them. And then you have pain syndromes that there's no nociceptive stimuli. So this is where you have the pain sensitization syndromes, phantom pain, post-surgery pain, brain injury where they have pain all over their body now. Then pain syndromes like complex regional pain syndromes or fibromyalgia, or just general chronic pain where the injury is no longer there. Those are non-nociceptive stimuli. So those are the two main categories of pain. Now, as we move on here, when you evaluate the type of pain, the standard approach is just what they, most of you guys know. Socrates is the term that's used for site, onset, character, radiation, association, time course, exasperation, and severity. So if you're doing a pain workup on pain evaluation in someone, you really want to see if they can go through these and give these an idea of fear. So remember, site, where the pain is, maximal site of pain, especially if you haven't done this in an exam. This is all somatosensory cortex. Onset, you want to know when the pain started. Character of the pain, that's insular cortex. Radiation of the pain, that's neuron convergence. And the associations with the pain can be very helpful for you because that can tell you what other types of metabolic factors are activating nociceptors. And then the time course, and then what things help exacerbate or relieve the pain. This can be very important for you for centralized pain. Like someone can say, I have lots of pain, but when I play video games, the pain goes away. And it's specifically this video game that I play. And that could be activating different areas of their cortex. Maybe they're playing a shooting game and they have to constantly shoot and do things, or maybe it's to getting the limbic system activated. But those are important. For some people, their pain will be relieved when they go on a certain diet. Maybe they fast and all their pain goes away. Maybe, they have to completely cut out sugar for all their pain to go away. But those are all clues to what could be driving it. So if someone's fasting, all their pain goes away, then there's some kind of dietary protein that's enhancing their nociception. If someone totally cuts off sugar and their pain goes away, then they definitely have some insulin blood sugar regulation issues that are really contributing to their pain issue. And then again, how severe the pain is. And the severity of their pain has to do with their ability to look at their cingulate cortex, prefrontal cortex, to determine that type of pain. So this is giving you some clues of what's happening. So every history should include these set of questions. Now, when you're looking at different types of pain, we have myofascial pain, sclerotogenous pain, vascular pain, degenerative joint pain, metabolic muscle pain, visceral pain, and neuropathic pain. And these are telling you the origin, the structures involved, and the mechanism of their nociceptive activation. So, you really want to try to clearly define these when you do your history. So let's go over what each of these types of pains are, and then we'll talk about what can amplify them, and then we'll go from there, okay? So degenerative joint pain. So degenerative joint pain is localized to the joint and worsens over time, often resulting in joint stiffness, right? So that's a degenerative joint pain scenario. Whether it causes pain sensitization down the road or not, it's based on multiple variables like we talked about, but this is ongoing active pain, that these chondrocytes are starting to deteriorate over time, and these chondrocytes around the joint, these tissues, as they wear off, they end up activating nociceptors and causing pain. So osteoarthritis is chronic pain, but in and of itself, it's not a sensitized pain syndrome. It's just there's ongoing active injury to the tissue, so there's ongoing active acute perceptions of pain. So this is still linear. Injury to chondrocyte, pain. Injury to chondrocyte, pain. Injury to chondrocyte, pain, right? So it's not like the joints heal and they continue to feel pain. Sclerotogenous pain. So sclerotogenous pain is reported by patients as deep, ill-defined, dull, aching, and diffuse. And the tissues involved here are ligaments, tendons, disc, periosteum of bones, apophyseal joints. So those tissues, when they get injured, can create pain, and they can also create sclerotomal pain referrals. So you could have someone with like a C8 ligament injury have pain all over their shoulder, right? Or pain all the way in their mid-back. But it's not related, but it's actually related to the ligaments in their neck being injured, but it's a sclerotome referring pain. And they may be misinterpreted as like neuropathies, but they're really not, because they have a different presentation. They have that dull, ache-like presentations. And again, these sclerotome referral patterns are just like visceral pain referral patterns. So in these senses, there's more proprioceptive, there's more primary neuron inputs coming in from the skin than there are from ligaments. So by the time these get processed at the brain, they really feel like the pain is coming from their skin instead of their actual ligament injury. So for example, the ligaments of C7 can refer pain to the mid-back, right? C7, C8. So if someone has a whiplash injury and they injure their ligaments and tear those ligaments, that area, which may take forever to heal because not really good blood supply there, they have more primary sensory inputs getting into their spinal cord from all the skin around their back and midbrain than they do from that C7 ligament area. So by the time it gets processed in the brain, they feel that their pain is actually all the way down here, right? That's the perception of pain. So those are sclerotome pain referral patterns. And then we have myofascial pain. So myofascial pain is disorder in which pressure on sensitive points of the muscles cause pain in seemingly unrelated body parts. The syndrome often happens after repeated injury or muscle overuse. Symptoms include persistent pain or tender muscle knots. So here, for example, in the upper trap, you can have a trigger point there. Trigger point's pretty straightforward to diagnose. You push on it, and there's pain referral, and there's pain right there. And then these myofascial trigger points, basically, when you look at the muscle fiber, there's an active tissue there. It contracts, and you can actually feel this. If you palpate, assuming you have basic palpation skills, and then if you push on the upper trap and pain goes all the way up to the eye and up to the chin and neck and this area here, then the origin is actually this trigger point. And fascia also have visceral refer pain in tissues. So there's lots of fascial movement and stretch. So when you activate an area, the convergence of these primary neurons from all the fascia, they get interpreted as the brain as input coming from all these different areas, and that causes that referral pain pattern. And there's lots of people that have like chronic headaches and migraines, and then they have these myofascial patterns. If you don't have Janet Travell's myofascial pain syndrome book, you should definitely have it. Every single office should have one of those when they're dealing with chronic pain patients. And you can basically go through the book and go, hey, I'm going to leave this book with you, flip through it, tell me if you recognize your pain. Then they may come back and go, yes, this is exactly my headache. Just like this. This is exactly how it feels. And then you squeeze their trap and go, does that hurt? They go, yes. Does it recreate your pain? They go, yes. That's a myofascial pain syndrome. It's not neurological based. It's not metabolic. It's this myofascial syndrome. And they happen from overuse and dehydration and a combination of variables. But the treatment's very easy. You get rid of these. And these have to be repeated over and over again. And then eventually, after a few days, they start to go away. So with myofascial pain can be defined as pain associated with inflammation, irritation of muscles of the fascia surrounding the muscle. And basically what they find is that there's abnormal acetylcholine release in the muscle that increases tension in the muscle fiber. There's blood flow constriction and hypoxia. There's disturbed mitochondrial metabolism. There's release of sensitizing substance, and there's pain and tenderness. And then this vicious cycle happens. And then this is easily released when the fascia around the muscle, is around the muscle is just manually massaged out, and then these trigger points go away. Okay. Now there's neuropathic pain. Neuropathic pain is initiated or caused by primary injury to the nerve. The pain is described as excruciating, burnings, pins and needles, and then temperature sensation. And then those types of neuropathic pain are really prone to causing the centralized pain because these activate microglia in the sympathetic system, and there's constant drivers to that. So someone could have like diabetic peripheral neuropathy, where they get the hands and glove distribution from the glycosid end products causing damage to the nerves. And why is it their hands and feet? Because that's the area with the poorest circulation. So areas of poor circulation with free radicals tend to destroy nerves in the distal hands and feet. Or you could have someone who has, let's say, for example, a disc herniation, and that disc herniation then causes nerve injury. Then even if the disc is removed, let's say through a microdiscectomy or some kind of surgery, and there's no longer pressure on the nerve, those nerve fibers are injured, the microglia are activated, they can end up with neuropathic pain and chronic sensitized pain. Especially if they have these mitochondrial oxidative ATP issues, and if they have other sensitizing nociceptor chemical factors involved. Then this is visceral pain. So visceral pain is vague, not localized, not well understood, or clearly defined. It is often described as deep squeeze pressure or aching. The deep pressure aching, pain, jaw, arm pain, classical heart attack type symptoms. And that's, once again, there's more input coming in from the soma, muscles, joints, ligaments, than the viscera to the spinal cord. So when these areas all converge, the brain interprets the input really coming from the soma instead of the viscera, and then you get these maps based on how these primary to secondary neurons converge on the spinal cord. And then you have metabolic muscle pain. In metabolic muscle pain, pain is described as muscle soreness, tiredness, or weakness. Muscles may ache during the day, and the pain intensifies with exercise. That's your classic reaction to statins that really uncouple the mitochondria. This is your classic fibromyalgia patient who just got this metabolic imbalance. A lot of these are Warburg effects we talked about, where as soon as they exercise, they immediately convert everything to lactate, and that lactate tends to cause that burning, soreness, tense pain that they feel. And many patients that have fibromyalgia really have that metabolic muscle pain. Pain is described as muscle soreness, tiredness, weakness. Muscles may be acting during the day. And then if you looked at some of the studies we talked about yesterday, when they do biopsies of patients with fibromyalgia, it's very clear that their muscle fibers are lacking in efficient mitochondrial function. So their bioenergetics to the muscle is impaired from a Warburg effect, or from things like statins that uncouple bioenergetic pathways. Here you can see like statins impacting this HMG CoReductase pathway, which then impacts mitochondrial ATP production. They get this muscle ache. They end up producing much more lactate because they can't convert glucose all the way down to acetyl-CoA. And then you have vascular pain. So vascular pain that is caused as a result of interpretation of blood flow to tissue or muscles. The pain is described as heaviness, numbness, weakness, or tingling feeling area of vascular supply. So that's vascular pain. So, as a clinician, you really want to go through and really describe the kind of pain that they actually have. You shouldn't just use pain. It seems like they have neuropathic pain. It seems like they have vascular pain, or they have muscle metabolic pain that really will help and explain things to anyone else who's reading your case notes or so forth, and also will help you remember the potential origin of their pain. So when you have someone come in and say, my arm hurts, you have to go through and go, is it neuropathic pain? Is it myofascial pain? Is it sclerotogenous pain? Is it metabolic pain? And once you kind of start going through that thought process as a clinician of what kind of pain it is, then you get to the origin of it. Or is it visceral pain, right? So that's the key thing. If you just go pain and go, well, it's pain, let me give you an anti-inflammatory, you're really wasting everyone's time. You're wasting your patient's time. You're not really doing a clinical workup. Okay, so that's why it's so important to name the kind of pain. So here's all the different types of pain that are named here: degenerative pain, sclerotogenous pain, myofascial pain, metabolic muscle pain. And some people can have more than one pain pattern. Now, what we want to do is understand how those different pain patterns can be amplified. So once you have this pain pattern, remember that nociceptors can be amplified by other types of chemicals. And when you're doing your clinical workup, once you identify the amount of pain they have, you want to go, are there any other amplifiers that are intensifying their pain, right? That will increase their pain patterns. So cytokines and histamines and hypoxia and insulin surges and adipokines and catecholamines, these all, when they mix together, can intensify pain, right? And then these can lead to sensitization patterns, which can then lead to vicious cycle pain syndromes. So I'll give you a few examples here. So let's someone has a disc herniation, right? And after that disc herniation, they have degenerative disc disease. And then from that degenerative disc disease over time, there's narrowing of that space between the two vertebrae, and now they have pressure put on their peripheral nerve. They have some of that disc fragment impacting their nerve now. They have a radiculopathy. Okay, maybe it's L4, L5, C4, whatever, it doesn't really matter. Then they have neuropathic pain. And that chronic neuropathic pain, they kind of ignored for years and years and years, and that chronic neuropathic pain is central sensitization. So then, because of degenerative disc disease, they lean away from their injury, and now they have gait antalgia, so they kind of walk with a little bit of lean, and now myofascial pain syndromes start to develop all around their glutes and all around their back. And because of their antalgic position, they have ligament strain. So now they have sclerotogenous pain. right? So now you have 4 types of pain. And if this is continued and unaddressed, this leads to peripheral and central sensitization. So you have degenerative disc disease, degenerative pain, neuropathic pain, sclerotogenous pain, and myofascial pain. Then maybe they finally go to a surgeon, and the surgeon removes the disc. But this neuropathic pain is not centralized. And they still have myofascial pain trigger points all over their body. And their ligament is still hurt. So now they go, oh, well, you might need a second surgery. Maybe there's something else going on. We can't tell. We have to go there and look and clean it up. And then they kind of get these repeated back surgeries and back surgeries and back surgeries because the orthopedic surgeon didn't take the time to go, is this myofascial, is this sclerotogenous, or is it neuropathic that's been centralized? Now surgeons are getting much better. They're realizing the concept of pain sensitization and these pain phenomena that take place, and not doing these multiple surgeries over and over again. But many, many, many people still are, and this is a problem. So if you take the scenario that we have here, and then you look at like sensitizing agents. So let's say they have the scenario. They have degenerative disc disease, they have neuropathic pain, they have myofascial pain, they have sclerotogenous pain. And then you add in amplifiers like free radicals, hypoxia, insulin surges. The combination of both of those would then cause pain, even different degrees of pain. So here's the question is, what would be the outcome of this example with these amplifiers? So degenerative disc disease, myofascial pain, sclerotogenous pain. And let's say they have prostaglandin imbalances, lots of pro-inflammatory prostaglandins, because all they do is eat food out of, box bags and chips and fast food, and lots of partially hydrogenated fats, lots of histamines because they react to the foods they're eating, and then they have leaky gut, and the LPS binds to toll-like receptor 4 and activates nociceptors. Well, their pain can be much worse. And in this scenario, maybe they have even more amplifiers. Their pain could be much, much worse. So they could have a surgical procedure and then have more amplifiers develop over time, and they feel like they're actually getting worse, even though the actual surgery was successful. So those are things you want to understand when you're doing your workup. What kind of pains, what type of pain patterns do they have? And then what are the amplifiers of these pains, right? And then another scenario, let's say you have someone with a sedentary lifestyle with obesity. So obesity is going to increase insulin, it's going to increase the adipokines, it's going to increase cytokines. It's all part of the metabolism of obesity. That's all going to cause systemic inflammation. You're going to have mitochondrial impairment from many of these mechanisms. Their ATP output is going to be compromised. There's going to be neurons close to threshold. They're going to have decreased movement. There's decreased activation of antioxidant systems when people are sedentary, so they don't really make many of their own antioxidants anymore. This can add to the nerve inflammation they already have. Their body weight may cause muscle recruitment, cause myofascial pains. They have strain on ligaments. They have sclerotogenous pain. So now they have, myofascial pain, sclerotogenous pain, some neuropathic nerve inflammatory pain. That's all happening. And, the question is, how many pain amplifiers exist with this case? Well, just the fact that they have prediabetes, metabolic syndrome, they have inflammatory cytokines, they have free radicals, they have insulin surges, they have adipokines from obesity. So, just if they can get the blood sugar under control and lose some weight, they don't have to become an immediate fit model with 6 packs, but even if they lose 5 pounds or 6 pounds or something, their pain level will dramatically go down. And then if they control their blood sugar insulin, it's going to go down much, much more. Now, let's say it takes this person that hasn't done anything yet, has all these amplifiers of their pain, and they go, okay, well, we're going to have to get you, to exercise. Well, if they exercise with these inflammatory patterns, they can actually get much, much worse and have much, much more pain. This is why some of these patients fail. So even though the ultimate goal with getting mitochondrial function is to get them to move, sometimes you really have to get their insulin and inflammation down. So in the Karadžić Institute Diabetes and Dysglycemia course, we talked about, for example, metabolic syndrome diabetes patients. You might have to get them to get their insulin under control, get into ketosis, get into fasting, get their antioxidants up for the initial parts of the management before you even have them start to get into exercise, so they don't totally fall apart and have injury and aggravate everything, right? So that just comes with experience as being a clinician. The easy model is go, oh, well, you're overweight. Go work out. That's why you're in pain. And then they go work out, and now they're much more pain, and then they're feeling worse. Now they feel bad about themselves. Now they're not recovering. Their pain patterns are worse, and they feel like a failure. But the real failure was not appreciating and understanding that these inflammatory mechanisms can really lead to immediate injury and inflammation until they're addressed. So maybe they have to work on those things first. And then if this person that has the sedentary lifestyle with metabolic syndrome, so what happens to them if they get trauma? What happens if they get an injury? What if this person gets a disc herniation? Well, they can have a lot of pain. They would have a lot of amplifiers. They have a lot of things that are already going there. So their severity of pain could be, let's say, much less than someone who gets the same injury that doesn't have these other factors involved. Okay, example number 3. So let's say someone complains of chronic mid-back pain. And then really what you find is that chronic mid-back pain is really, they have some gallbladder sludge, pre-gallstones. They get visceral referred pain, especially when they eat fats. And they have some intolerance to foods. In addition to that, they have decreased intake of healthy foods. They start to have lots of prostaglandin shifts. So now they have prostaglandins amplifying their pain. And because of the gallbladder sludge, they're not able to release bile salts. Remember, bile salts are critical for activating different receptors in the gut, like CKR receptors in the gut and G-coupled proteins to modulate healthy microbiome diversity. And the fact they have decreased bile salts, they have dysbiosis, they have permeability, that leads to LPS activation, endotoxemia as gram-negative bacteria release lipopolysaccharides from leaky gut, the multiple food sensitivities, and they have this chronic mid-back pain, but it's really due to visceral mechanisms and this sludge. And they get massage on it every week, they get manipulation on it every week to do everything to get rid of their pain, but it's really related to this gallbladder-related area in combination with their prostaglandin shift and their intestinal permeability that's leading to chronic pain. So the chronic pain syndrome may need to have these underlying triggers removed. So, the question, what factors could impact the gallbladder pain and mid-back? Well, it's all these triggers that are clearly there if you do your history. Number 4, example of pain number 4. Let's say someone has piercing blade injury to their quadriceps. Let's say they got stabbed there, okay? Maybe they were playing with the knife themselves and they stabbed themselves, right? That makes it even much more fun. 4 years later, they still have symptoms of burning, stabbing pain despite healing of the injury. So this is neuropathic pain. So this is central sensitization, right? And what factors could impact his ongoing pain? Well, ongoing pain, of course, he injured himself. And then you see a scenario like this, you're like, well, he injured his nerve is permanently injured. Like, what do you want? What can we do? It's like, just there. Well, you can do things. And if you can go in your history and find out all the different nociceptive amplifiers, you can decrease the amount of pain and suffering and nociception experiences throughout the day. So you still want to go through and do your workup. Okay? So let's get into clinical evaluation of nociceptive amplifiers. And these nociceptive amplifiers have multiple clinical applications. If you have someone who's got ongoing pain, like RA, or someone who's got degenerative joint disease, whatever the scenario may be, if you can identify these other nociceptive triggers and remove them, then you're going to immediately decrease their suffering and their pain perception. For people that have these multiple nociceptive triggers activated, that can then lead to sensitization chronic pain syndromes. So that's another application. And if you have a chronic pain syndrome, you're going to have to improve the mitochondrial pathogenetics at the same time as you remove these nociceptive triggers in order for them to have a chance to break out of that vicious cycle. All right. So let's talk about these individual nociceptive triggers. So inflammatory cytokines from immune cells. So just remember, all your immune cells, macrophages, monocytes, T cells, they're all B cells, they're all going to release these cytokines, right? And this is a paper that is great to read, called Immunocytokines and the Receptors in Inflammatory Pain. But they go on to show that cytokines are now recognized as important mediators of inflammatory pain. They can induce nociceptive sensitization indirectly via mediators where neurons become primed and thus become more responsive to stimulation. Alternatively, there's also evidence that cytokines can directly activate neurons via their specific receptors present at neuronal cells. So even if you don't have an injury, cytokines themselves can activate pain fibers directly itself. So, in the past, it would be weird to think, well, if someone has gut inflammation, how would that cause pain throughout their body? If someone has a, inflammatory lung condition, how would that cause pain throughout the rest of their body? Well, the answer is pretty simple. These inflammatory cytokines are systemic. They're all over the body. And wherever there's a fire, they just add fuel to the fire. They make everything worse. They amplify pain wherever there's already activation of nociception. So here you can see an illustration of, for example, all different immune cells, neutrophils, macrophages, lymphocytes, mast cells are being activated. They're releasing cytokines all throughout the body. And here you have a knee. You have a knee, maybe a knee is injured. But these inflammatory cytokines are also activating the nociceptors in the injured knee. Now they have lots of pain that are happening. So now their knee pain is getting worse from their infection, from injury, something that's systemic. So whenever you're doing a workup on individuals, you really want to look for, are there any infections? Are there any dietary protein reactivities? Are there autoimmune reactivities? Are there any inflammatory conditions? So the most obvious one everyone knows is if you have chronic pain, try to find whatever is causing inflammation and reduce it. It's very obvious. But it's very important. So these cytokines can increase sensitized pain. Now, your clue that some people have these inflammatory mechanisms are happening is, first of all, any change in your lab tests, like immune function tests, like T cells, B cells, neutrophils, lymphocytes, there's something happening to these cytokine pathways. But also, you can look at acute phase reactants, like C-reactive protein. C-reactive protein is just basically a cluster of proteins, cluster of cytokines that get to the liver and get metabolized to protein, which is now called C-reactive protein. And then ferritin, another acute phase reactant we talked about, that can go up when there's lots of cytokine activity. And then the sedimentation rate, ESR, can go up when there's lots of inflammation. And sometimes these labs will not catch it. You can have someone get severe inflammatory reactions and the C-reactive protein and ferritin and ESR are totally normal. But if they're high, then there's definitely something that's happening. So those are things to keep in mind. Now, prostaglandins are another major mechanism of pain. And remember, when you look at prostaglandins and leukotrienes and prostanoids, they have both beneficial and inflammatory potentials, right? So when you look at, for example, remember the COX-1, COX-2 cyclooxygenase pathways, and then like COX-1 pathways actually help tissues heal. They help your gut lining heal. They're important for your general tissue regeneration, and COX-2 pathways inhibit pain and inflammation. And those are because prostaglandin 2s can really cause some inflammatory types of reactions. So whenever we have someone with a chronic pain syndrome, we want to look at their prostaglandin levels and the kind of fats they're eating. So as soon as you see pain, you jump into, well let's talk to me about their diet. And you want to see how much of their food is coming from partially hydrogenated fats. Partially hydrogenated fats are anything that's in a box or in a bag. So potato chips, cookies, frozen microwavable food. There's lots of partially hydrogenated fats in there, right? And then like dietary fats, like saturated fat, how much red meat, dairy, fat products they eat. And then how much essential fatty acids they eat. Essential fatty acids would be you want to look at things like olive oil, fish oil, nuts, seeds, healthy fats. And then ultimately those get converted to prostaglandins. And you need to have some pro and anti-inflammatory fats. You really don't need any partially hydrogenated fats. But then prostaglandins are actually endocrine signaling agents. They help with endocrine balance, they help with blood flow, they help protect tissues, but they're also nociceptive activators. So here is the thing you want to do when you look at your dietary history. Figure out how much omega-3, 6, 9 arachidonic acid that they're consuming. These arachidonic acid pathways have a greater tendency to go into pro-inflammatory prostaglandins. And you also want to balance between 3, 6, and 9. So in the infertility course, we talked about all the research of prostaglandins related to premenstrual syndrome, pain, pelvic pain, cramping, and how important it is to get these under control, and how important it is for having healthy fatty acids for healthy neurodevelopment. But when you're dealing with pain, this is also another issue where prostaglandin balance is really critical. So you want to look at their diet and see if they're getting all types of different sources. And if If you're eating lots of animal butter, fat, seafood, fried food, partially hydrogenated food, and not really getting healthy amounts of like olive oil and fish oil and nut seeds and healthy fats, then they can really be promoting a pro-inflammatory state. So you want to go in there and use things. Now, here you have your omega-6 oils, canola oil, sunflower oil, grapeseed oil. People always talk about canola oil being rapeseed oil. But there is cold-pressed organic rapeseed oil, which is a really good source of omega-6. You can get it in health food stores. So that's a really great way to raise omega-6 levels as well. Okay, and then if you look at here, you can see, for example, the arachidonic acid pathway gets activated, prostaglandins get activated, the carboxamines get activated. The carboxamines cause clotting, they cause vascular pain. Arachidonic acid directly activates nociceptors. Prostaglandin 2 directly activates nociceptors. So if they have that diet with the wrong kind of fats, they can definitely start to have increased pain. Pelvic cramping, pelvic pain, systemic inflammation, even mood changes that take place. So when you see a patient that's dealing with lots of pain, you definitely want to go in there and do your dietary history of pain. And here you can see an illustration of prostaglandins directly activating pain fibers and then really leading to inflammatory pain patterns. So if you have an injury anywhere, or if you have pain fibers being activated for one reason or another, all prostaglandins, the pro-inflammatory prostaglandins will do, is they will add fuel to the fire, and they'll make everything much, much worse. So pelvic pain, blood flow, those are all things. And if aspirin, for example, helps their pain, it really suggests they have a prostaglandin imbalance, right? So I take aspirin, I feel a lot better. That's impacting these prostaglandin pathways. Okay. Now, here you can see things like diet. So if the diet is really high in animal fat, saturated fat, fried food, shellfish, red meat, standard American diet, and low in fatty, oily fish, this doesn't include fish sticks, raw nuts and seeds. That does not include like peanut-covered M&Ms. And then olive oils and avocados. If they have actually healthy fish, fatty fish, and they actually have healthy nuts and seeds, not the dry roasted stuff, but actual healthy nuts and seeds, and have those good fats, they can shift out of that prostaglandin balance. So you may have a chronic pain patient and go, listen, I really need you to increase your olive oil. I need you to really increase your flaxseed oil. I need you to eat healthy fats. You got to get off these partially hydrogenated crap until you start to get your pain pattern under control. So those are where you have health when you look at these mechanisms. So these pro-inflammatory prostaglandin promoting pathways increase activation and sensitization. Now, when you're evaluating these, diet is really the most effective pathway to really figure out what's going on with this. Assuming your patient's giving you accurate dietary information. And then you can run red blood cell essential fatty acid profiles, and these are accurate to really determine the content of omega-3, omega-6, omega-9 oils. And with chronic pain patients, you want to try to get these balanced out. Realize that these essential fatty acid markers can shift not just by what they're consuming with their diet, but how much inflammation they have in their body. So you can see, for example, they have lots of inflammation in their body, and their omega-3 fatty acids are low, and they're already taking high amounts of omega-3 fatty acids. It just indicates that you either have to dampen their inflammation, or you may even consider having them taking more of the source that they're low in. So as you evaluate pain, in addition to looking at inflammatory cytokine mechanism and inflammation, look at their fat intake and look at their prostaglandin balance. So the next amplifier of pain is histamine. So basically histamine is released by mast cells, and histamine is an excitatory neurotransmitter, and histamine is an excitatory neurotransmitter that directly activates nociceptors, pain fibers. So if you have any kind of trigger activating an IgE response, right, a mast cell histamine-related response that can really amplify pain. And here you can see a scenario where they show in the study mast cells, neural interactions in health and disease, and they really show when these mast cells get activated and they create the inflammatory responses, one of the immediate effects of higher histamine levels is hyperalgesia and pain. And this histamine response doesn't just activate peripheral receptors, but histamine levels in the blood cross the blood-brain barrier, and histamine can activate pain perception even in the brain directly. And histamine levels also activate microglia, which then turn on the neuroinflammatory response. So having any type of IgE reaction with a pain syndrome, pain pattern is really going to amplify everything. So part of your workup is to go through and try to identify, hey, do you have any seasonal allergies? Do you have any food allergies? Do you have any environmental allergies? Do you have any infections? Do you have any mast cell activation syndromes? People are so focused on food sensitivity versus food allergy, they don't realize like a food allergy can cause a lot of pain. So sometimes it's really important to run an IgE food sensitivity panel, not just an IgE food allergy panel instead of an IgG food sensitivity panel. And then seasonal allergies. You definitely want to look for IgE related issues. You want to look at IgE for mold, see, especially if they have sensitivities to damp buildings. And then infections, especially parasitic infections, they can definitely activate the IgE response, right? And some people actually have mast cell activation syndrome. But if their histamine levels go up, they have increased sensitization. One of your clues, by the way, that this is happening is if you look at a routine blood work, eosinophils are going to go up with IgE activation, mast cell activation. So if you ever look at your blood work and you see eosinophils elevated, then you know that you have some kind of IgE response that you want to look for. You can also measure things like serum histamine, but you have to have very high levels of serum histamine. Here is a patient with chronic pain. Look what you see here. You see very high levels of histamine. Histamine in plasma, histamine levels in blood. They have lots of antibodies to mold species. So this is a chronic pain patient. These things are sensitizing their pain. So in order to get them out of their pain, we got to get them out of their mold environment, and we need to get their histamine reaction under control. Also, if you're looking at these mast cell, these IgE reactions, you can just look at total immunoglobulin. You can do a immunoglobulin profile, and if their IgE immunoglobulins are high, then you know you have to start searching for an IgE histamine-mediated reaction. And also when people have histamine-mediated reactions, they get flushing, they get redness, they get something called dermatographia, where like you can write on their skin, and then you can see their handwriting on their skin. That's a reflection of too much histamine in their blood. Okay, so then you get to free radicals. So free radicals definitely amplify nociceptors. And we talked about exercise before, but just realize that one of your clues that someone has free radical imbalances is that they just don't do well with exercise. They actually get more pain, more inflammation. They fall apart with exercise. So here they show like healthy controls, and they show that in general, they have way more antioxidants than they have inflammatory mediators, right, or free radicals. So they exercise and they actually have it help their pain because exercise then releases opioids and endorphins, and they just feel much better afterwards, and life is good. But patients that have chronic widespread pain syndromes, many times they have lots of free radicals, you can see here, and more free radicals in their antioxidant capacity. So when they exercise, they have hyperalgesia, and their body hurts more, and they can't recover. And then this has different degrees. Then you have like the patients that have myalgic encephalomyelitis, chronic fatigue syndrome. They exercise, they don't just have a little more pain, they're like not functioning for 4 days, 2 weeks at a time, because it completely shuts down their metabolism. So that's like the extreme case of it. But the key thing is, like they're illustrating, is you really have to have antioxidant levels up. So if someone tells you like their pain is dramatically worse when they exercise, one of the things to always look at is they may have very low antioxidant status, and you may want to really focus on getting their antioxidant levels up. So conclusion, a combination of antioxidants with analgesics normalized both oxidative stress and functional indicators. These results suggest that administration of antioxidants in pain treatments may be employed to decrease the dose of analgesics and to prevent negative impacts of reactive oxygen species and nociception. So this is a paper that was published in Neuroendocrinology Letters, where they gave patients that had pain syndromes the conventional approach of analgesics, but they also gave antioxidants. And the group that got antioxidants, they didn't have to use as much pain medication, which is a great thing, right? So antioxidants themselves have this pain effect. May not completely get rid of the pain, but it adds to lowering the volume of sensory inputs to the nociceptors that then can really cause some severe nociceptor sensitization. And then here's in addition to antioxidants, they really show that exercise has impacts also on the autonomic nervous system. So when people have increased pain, increased oxidative stress, acute exercise can make them worse. But when people actually exercise, they get physical training that activates their parasympathetic system, and then their acute oxidative stress and patterns on the long term go down. So there is autonomic impacts as well with exercise and free radicals. And this was a study where they looked at, they induced pain, and then they looked at different antioxidant type mechanisms, and T-bars is a free radical. So control groups, you can see here, that did not receive any painful stimulus, they're white, and they're the same for all 4 of these groups. And immediately when they induce pain, just the nociception itself, they can see superoxide dismutase levels go up, glutathione levels go up in general. So just the activation of nociception starts to use up antioxidants. Your body releases antioxidants. And that being said, when people are in chronic pain, their body is using up their antioxidants. They're releasing and using it. It's a reflexive cellular response. So people that have chronic pain syndromes start to have depletion of their antioxidants. And then if you have depletion of the antioxidants in addition with something like smoking or environmental chemical load that's adding to their depletion of antioxidants, or lack of healthy flavonoids and sulfur foods in their diet, then you can get someone who really has lots of pain generated by free radicals. So things like cigarette smoke, traffic car exhaust, cleaning chemicals, pesticides, air particles and air pollution, overtraining, cancer, radiation, all increase free radicals. So just being stuck in traffic and just inhaling car exhaust is going to be a huge source of free radicals, right? Cleaning agents can be a huge source of free radicals. Air pollution can be a huge source of free radicals. The things that raise antioxidants is exercise recovery. So during exercise, you raise free radicals, but after exercise, you get a rebound production of antioxidants. Colorful fruit and superfoods. The so-called like rainbow diet, where you get as many different colors as you can to really improve your antioxidant status. Tea and coffee are loaded with antioxidants. Green foods, sulfur foods, these things are all important. So if someone has much more free radicals antioxidant activity, and chronic pain itself will deplete antioxidants, they have increased oxidation and then sensitization. You can look at surrogate markers for oxidative stress, like lipid peroxides or 8-OHBG, which are mechanisms, surrogate markers for oxidative stress injury to get an idea of where a person's at. You can also look at oxidative stress markers in the serum, which we're going to give you more profiles of different mechanisms involved with free radical production, like glutathione peroxidase and superoxide dismutase and lipid peroxides and so forth. So this can give you a clue. Combination of urine and blood are nice. Urine is sometimes better than just blood. Okay, hypoxia. So another mechanism that increases nociceptor in pain is just lack of oxygen in the blood. So hypoxia decreases when someone has decreased oxygen in their blood for whatever the mechanism may be. The heart rate goes up, they have rapid breathing, they have fatigue, they have changes in skin color. So if you ever put a pulse ox in a person and the heart rate goes up like crazy, you definitely want to make sure they're not dehydrated, and you might want to make sure they don't have hypoxia. Then you can look at their pulse ox. If their pulse ox is less than 94, then you know they have some kind of respiratory, cardiac issue that's not getting oxygen to their tissues. So be aware of that. If the heart rate goes all over the place, up, down, that's a clinical indication of dysautonomia, which can also be important when you look at pain syndromes. And this is the key thing with when you see hypoxia, anemias, anything that decreases cardiac output, anything that impacts his pulmonary function, like allergic asthma, occupational asthma, poor circulation, sleep apnea. These things all increase pain sensitization. These are also the same things that decrease mitochondrial ATP production. There's overlap between those two. And then insulin surges, dramatic mechanisms of pain induction. So insulin itself is going to amplify inflammatory responses with nuclear factor kappa beta. It's going to activate those genetic responses that then produce these pro-inflammatory cytokines. And then if there is advanced glycation end products produced from uncontrolled blood sugar elevations, they're going to bind to advanced glycation end products through the RAGE, receptor for advanced glycation end products, and then create systemic inflammation. So whenever you're looking at people that have pain syndromes, you want to look at their insulin levels, fasting insulin levels, and you want to also look at their amounts of glycation that they have. So you can look at their HbA1c, fructosamine. If these are high, that alone is going to absolutely cause significant pain, activation of nociceptors, and promote chronic pain syndromes. Then you can look at glucose and insulin fasting. It's just a one-time. You can do a HOMA calculation, or you can look at postprandial glucose levels of insulin to determine if they have any insulin patterns. Here you can see someone who had a 2-hour insulin surge. After 2 hours, they had to show their insulin surge. So maybe after they eat, actually after an hour, their insulin levels surge. Maybe an hour after they eat, they really feel a lot of pain, especially if they eat foods that are high in carbs or high in sugars. And then glycosylated end products, we just talked about. But when free radicals bind to glucose and become these glycosylated end products, those end products can cause significant pain and discomfort in people. So here you see a summary of those mechanisms. Insulin surges activate pro-inflammatory prostaglandins and then activate adipocytes to release inflammatory cytokines. They all increase systemic inflammatory cytokines. They cause increased pain sensitization. And then if there's advanced glycation end products promoted, they directly bind to receptors for advanced glycation end products, and that really increases pain perception as well, right? So things like HbA1c, fructosamine can be useful markers. Glycomark is just going to look at spikes, but they can also be useful. So you can look at those through, routine lab tests. And then adipokines in the body, simply put, body fat increases pain. The more body fat a person has, the more adipocytes release inflammatory adipokines. Inflammatory adipokines sensitize pain. Catecholamines, I don't need any lab tests for that. You can just do your BMI, your visual inspection, and just be aware of that as a factor. And then catecholamines. So catecholamines can increase pain activation. So here they show that we conclude that sensitized mechanoreceptor and sensitive nociceptors can be activated by endogenous release of catecholamines and thereby may contribute to sympathetically mediated pain. So here's an illustration of this. So if you have like traumatic brain injury or anxiety disorder, PTSD or dysautonomia, these things all increase the sympathetic response, which means there's activation of that intermedial cell column of the spinal cord that fires into the sympathetic chain. Nerve fibers get activated. Nerve fibers release substance P. Substance P sensitizes nociceptors and tissues around it, and also just catecholamines from the sympathetic response activate pain fibers as well. And then the substance P neuroinflammatory response, again, is just that whole stress pathway where these substance P compounds get released that we just went over. And then low cortisol patterns. So when people have these low cortisol patterns throughout the day, that's been associated with fatigue and pain syndrome. So here's a longitudinal course. There's a study that they did, and they found low cortisol response to stress is associated with musculoskeletal pain combined with increased pain sensitivity. Young adults was a long longitudinal cohort study. So when there's reduced cortisol levels, there's inability to dampen inflammatory responses, increased cytokines, increased prostaglandins, increased histamine, increased free radicals. That all leads to sensitization. Now your clue, someone has low cortisol, is they're hypoglycemic. Constantly are fighting to get their blood sugar stable because cortisol is what you need to break down glycogen. So people have low cortisol, they're usually always struggling with, getting the blood sugar back up, eating frequently all the time. So, your patient that has, they're underweight, they're not overweight, they're underweight, and they're constantly hypoglycemic, until you get their blood sugar stable, you may not be able to get them out of pain. So that's really important. And then leaky gut patterns with endotoxemia. So if someone has a healthy gut barrier, that's great. If they have a healthy gut barrier plus dysbiosis, these gram-negative bacteria can get into the bloodstream. That's called endotoxemia. And we talked about this in the Cross Institute GI course. But these lipopolysaccharides that cross have the ability to then bind to toll-like receptors that create systemic inflammation, and those things then sensitize and lead to chronic pain. So here you see intestinal permeability and dysbiosis, LPS from gram-negative bacteria go into systemic circulation to get endotoxemia. LPS activates TL4 receptors in immune tissues, cytokines, and then sensitization. You can check for that with panels like this, or they look at leaky gut markers. Actomycin, including zonulin, are there to determine if they have intestinal permeability and breakdown of the tight junctions. And if LPS is high in their blood, that means that they have endotoxemia, and these LPS particles can then activate the inflammatory response. So with chronic pain syndromes, with people that have an injury and their pain just gets worse, then you can look at these key mechanisms. You even may want to print this diagram out and then say, hey, we have to go through this list to see how to get your pain under control. I made you a chart that goes into all the different clinical symptoms for each of these drivers of nociceptors. So with inflammatory cytokines, there's increased inflammation in injured tissue, systemic pain, brain fog, prostaglandin imbalances. There's increased pain after foods that are typically partially hydrogenated, fried or high in arachidonic acid. With histamine reactions, there's in the clinical workup, there's the signs maybe like they have increased hives, rashes, eczema, nasal congestion, sinus issues, migraines, itchy skin in their eyes. Free radicals, there's usually increased pain after chemical exposure or exercise. With hypoxia, there's increased pain associated with respiratory issues, anemia, and poor circulation. Insulin surge patterns, there's fatigue and sugar cravings after meals, and high sugar meals increase pain. With glycosylated end products, increased pain when eating foods highest in advanced glycation end products. Remember, like foods like fried food, cheese, and processed products are also glycated. So anytime you eat food that's been browned or bronzed, that makes it taste great, but those are glycosylated end products. For some people in chronic pain syndromes, that does make them worse. And adipokines, just see if they have any types of obesity, substance P, medical conditions impacting brain sympathetic response. Low cortisol, difficult waking up in the morning, tendency to hypoglycemia, microbiome dysfunction, bloating and distension, signs of maldigestion, multiple food sensitivities. Those are your clues for some of these driver pathways. And then I made you another diagram that instead of the clinical signs and symptoms, it goes into labs and exam findings. So for inflammation, CRP, ESR, ferritin, cytokine levels, swelling at the body and face would be your exam finding clues. Prostaglandin imbalances, you can run an essential fatty acid profile. And then unhealthy skin, hair, and nails could be clues to you. What's going on. Histamine, you can measure serum histamine, total IgE, to food, to environmental agents. And facial swelling, itchy skin, nasal congestion can be clues there. And then free radicals, oxidative stress profiles can be done for serum and urine to look at their free radical status. And just the appearance of advanced aging is always a clue to you they have free radical issues, right? So if they look like they're older than they are. For hypoxia, you want to run things like a CBC, things like pale nail beds, pale skin, cold extremities, increased heart rate. Those are factors there. And then insulin surges, again, fasting blood glucose, fasting insulin, postprandial glucose, homocalculation, and then exam findings, things like skin tags, canthos, nigrans, androgenic alopecia, and thalassemia. We went over these images yesterday because they also correlate with fatigue syndromes. Glycosylated end products, you can look at HbA1c, fructosamine, glycomark, appearance of advanced age, obesity, catecholamine, obesity, just look at body mass index. Catecholamines, you can measure your catecholamines, but they're not going to really go up unless it's severe catecholamine releases. So they're not that reliable. Neurogenic inflammation, there's really no labs, but swallow tissue and redness of skin, pain, especially after stress responses, are all clues of neurogenic inflammation. And then autonomic changes of the skin are all clues of neurogenic inflammation. Cortisol, you can look at salivary cortisol. No really exam finding for low cortisol. High cortisol, you get that Cushing's type pattern. Lipopolysaccharides, no really specific exam finding for those. So you want to do testing. So those are the key things to look at, the drivers, the amplifiers of nociception. Okay. And then you want to get into your exam. So those are the things you want to think about through your history, through your workup, through your evaluation, and then when you look at your exam. So when you do an exam, I'm just going to talk about how to do a focused sensory and autonomic exam to evaluate sensitization without advanced equipment, advanced tools, and just looking at your basic, perception of sensations, and then looking at some very simple things for autonomics, like people responses, heart rates. You can obviously do very advanced autonomic testing with clinics that are focused on doing like tilt testing and looking at heart rate variability and looking at people responses with different stimuli and so forth. But those require referrals. You got to make sure you know your dermatomes as a clinician. It's funny how many people don't know their dermatomes. You got to know your sensory distributions when you do a sensory exam. These are for peripheral nerves. And then key concepts: loss of sensory perception on side of the body, not specific to a dermatome or peripheral nerve sensory distribution, is typically associated with parietal lobe dysfunction, just how the brain is perceiving pain. And bilateral loss of sensory perception, whether it's hyperalgesia or allodynia, is really associated with metabolic types of conditions. So remember that when you give a noxious stimuli, let's say the noxious stimuli is a pinwheel, if they don't feel it as prickly, that's hypoalgesia. If they feel it, that's nociception, which is expected. If it's really, really sharp and painful, that's hyperalgesia. If you just touch their skin and they have pain, that's allodynia. So let's just go through basic things on a sensory exam. So here we go. Here's some just video footage of just the basics.
Jelly, have you close your eyes. When you feel the tissue on your skin, just point to where you feel it. Okay, great.
So just taking a piece of napkin and then having it localized where she feels it. And this is telling me what? This is telling me that she has some autotopic activation of her cortex. That light touch, she can discriminate where the pain is. She can discriminate that. If she has pain syndrome, let's say her right body hurts and then she can't feel the pin, she can't feel the light touch, then in her parietal lobe, let's say, it could be injured. Now, if you touch different areas with a napkin and it causes significant pain, then you have allodynia, right? Then you have pain sensitization. So with her, she was able to localize it and she didn't have any significant pain. So I know she doesn't have, a very clear level of central sensitization, and then that her parietal lobes are intact. You can check other sensory inputs just to make sure things are okay too. This is just your basic vibration test, where you just take a tuning fork, see if they can vibrate, and then you stop and see how that goes.
Okay. Just close your eyes. Mm-hmm. You feel that vibrate? Yes. And it stops. Stop. Close your eyes. You feel that? Yes. And when it stops. Stop.
Okay. And vibration sensors become really important if you're especially looking at neuropathies, like diabetic neuropathies, because large fiber neuropathies are more common with diabetics. They do get some C fiber activation too, but as they lose their large fibers, they lose perception as well. Now, with people that have chronic pain syndromes, you're doing these sensory tests not so much to see if they have a peripheral nerve injury. You're doing these sensory tests because these are really great representation of what's happening in the brain, that they're able to perceive pain appropriately, that they don't have allodynia, hyperalgesia, and that the parietal cortex is actually working. And then stereognosis, here we go here.
Your eyes. With your hand. Tell me, feel what this is with your hand. Kind of like a paper cut. Great. And then feel what this is. A piece of paper or something. Not a rubber band. It's falling apart. Okay, great. Paper, wood.
Right. So that would make it a little concerned that she had such a hard time with that. But so you want to do maybe further testing and see that she can actually identify what the object is. And these are looking at parietal lobe discrimination aspects. And remember, the parietal lobe is where you localize and perceive pain. Then you do tests like graphesthesia.
Okay, I'm going to draw a letter off your hand as if you're reading. Tell me what letter this is. X. Okay. And this one. It's either a D or an O. Okay.
See, on the left-hand side again, she's having a hard time between D and an O. She's a hard time recognizing the rubber band. So if I was looking at her pain syndrome, I'd go, okay, her parietal lobe may not be so healthy. Her brain on the contralateral side may not be so healthy. Part of the reason she may have a pain syndrome is that she doesn't have healthy descending pain inhibition potential activation there. And then you really want to focus on their mitochondrial health and anything you can do to improve their brain health, maybe dampen your inflammation, and then you dig a little bit deeper there. So let's look at parietal extinction. This is a really important test. So let me show you how this works.
Chain second. Your pointer fingers are number 1. This is 2. This is 3, and that's 4. Okay. Close your eyes. Which one am I touching? What number? 2. Which one am I touching? 3. Now, don't move your hands at all. Oh. Which one on the left? Left. 3. Which one on the right? 2.
So basically, you have them feel each individual finger one at a time, and then they can name it. And then once you have them do the left and right side, you touch like the second finger on the left hand and maybe the third digit on the right hand, and then have them name it. And that really requires really good parietal lobe integration. You can see she had some problems again with her left side. So right away, that's not a healthy brain. That's not a healthy parietal lobe. So she's got some kind of sensory disorder. And here's the thing. If her left hand gets injured, she's probably going to end up with the pain syndrome because she already has inappropriate sensory recognition of that side of her body, right? And if she has that with sympathetic increases, she may be a candidate for like RSD. So these types of simple assessments can be very useful to you. Again, you're not doing these sensory assessments for like a peripheral neuropathy or radiculopathy or something like that. You're just getting an idea of how their brain perceives different types of sensations. And then another really good test to evaluate the integrity of the parietal lobe is there are these intertangled fingers. I'll show you how this works.
Go ahead and move your middle finger up. Okay, and do it one more time. This time eyes open. Eyes open. And move your left middle finger. Great. Okay. And then follow my hand. Do what I'm doing. Great.
So just want to see if you can have patients move their hands like this and say, move your middle finger on the left or right and see if they can do it. And if they can't do it, that really tells you their parietal lobes are healthy. You can switch your hands in different positions and have them do different things. It just makes it more complicated because now they have to feel left to right and then move their limb. And then another key question is very easy to see what's going on with their brain health and how they perceive nociception and pain is just ask them to perceive different parts of their body if it's the same from left to right.
Right. Go ahead and close your eyes. Try to visualize the right side of your body. Can you have it say now? No. Visualize the left side. Now. Is there a difference between one or the other? No. Okay. Great.
Now, that's just one side or the other. Really, the best way to do it is, like for her, I want you to feel your right hand and left hand because we saw something's wrong with her left hand, right? Or I want you to do your left foot or right foot. And if they have like an ongoing injury to one side or pain perception on one side, that's the side you want to have them close and see if they have some perception issues there. And if they have issues with perception, then you know that there's some involvement of the brain, and the brain, if it's not functioning well, then you know that descending inhibition pathway may not be so ideal. Then just some very basic autonomic stuff. Obviously for autonomic exams, you look at their skin, you look at their pupils, look at their heart rate, you see how things are going on. Pulse oximeter test is a very simple test to do. And basically with the pulse oximeter, you're just looking at their heart rate and their pulse ox. Pulse ox is good for oxygen saturation. Just look at the heart rate. See if the heart rate's really high, see if the heart rate's really low. People in the increased sympathetic tone are going to have really high heart rates. People that have dysautonomias have heart rates all over the place. Those are things to look at. You want to look at pupils. This is the pupillometry where we're looking at the pupils with the VNG machine so we can really see them really well. You don't need fancy equipment for that. But when lights go off, people should dilate. And then they go on, they should constrict, but hers are not dilating. And then this is a abnormal pupil response. So that can be found with some patterns of dysautonomia in chronic pain patients. And then we showed you this allodynia case before. So allodynia, you just do any kind of light touch to the area of injury. You should always go around the area of injury with like a tissue or a paintbrush and see if they have pain. So here you can see.
I'm going to apply this light brush to the area of your complaint. Please let me know how that feels. Ow. Okay. What does that feel like? Like a sunburn. Okay.
right? So anytime you see that, you know you have sensitization that's happening, right? It's peripheral, central, at the nociceptor, at the spinal cord, at the brain. And then you immediately have to go through your list of amplifiers, figure those out, and you immediately have to improve mitochondrial bioenergetics, everything we talked about in part 1, to get this result. Okay? Here's another scenario, L-adenine in the back. So this gently gets touched in the back here with a monofilament. A monofilament is just a very flexible piece of plastic. It shouldn't hurt at all. You can look at the muscles here. That's not a needle. That's just a very thin plastic filament. See that? Severe withdrawal spasm, really chronic pain. That's allodynia. And this could be a person that could go, listen, let's go through history and diet. And they go, well, I always forget to eat. I get shaky, lightheaded, irritable. And they go, okay, only thing I want you to do the next 3 days is eat every 2 to 3 hours, high protein, high fat, get off the sugar and fruit. Let's just see how your pain is. And they can literally come back in 3 days. You do that same test and it's like 80% better. So that's not unrealistic. Or you may have to do multiple things to get that change. But that's the thought process that you want to go through. Here's another patient. I want you to see here with the pinwheel. When you guys do a pinwheel exam, comparing one side to the other, I'll actually show you details of this case when we do case studies. This will be one of the case studies I'll show you. But I ask the patient if they feel the pain. If one side is worse than the other, or if one side has greater perception of hyperalgesia, the second question I ask is, when does the pain go away? So if you take a pinwheel and go, does this feel the same left to right? They go, yes, perfect. They go, no, this side feels more. You go, okay, do you still feel it? Yes. Tell me when that pain sensation goes away. And you time it. I'm like, you're timing it. You're going, they still feel it. And you go, you still feel it? They're like, yeah, okay. Tell me when it goes away. And you time it. It's like 90 seconds. Like you felt that for 90 seconds. So like, yeah, that's hyperalgesia. So you can actually time it. And then you can get an idea of where they're at. So maybe, as things get better, it's only 10 seconds or 2 seconds, or then eventually normal.
You still feel it? Okay. Okay, tell me when it starts to go away.
I'd say no.
Yeah, would you?
Yeah, more on the right, but it's gone away.
Okay.
So it's not so bad. So for some people, it gets much, much worse. I'll show you the rest of this exam later. Okay, so now this is exaggerated withdrawal reflex. I'm just doing a Babinski stroke in her foot. We're going to see her entire body goes into withdrawal reflex.
Oh, sorry. It's an exaggerated reflection withdrawal response.
You see that trunk move? I'll show you that one more time.
Or take
See
a
that?
little on this one?
Yeah.
Okay, so exaggerated reflective withdrawal response on the right. Let this relax. Is that your shoulder?
Yeah, I have frozen shoulder.
Okay. On the right side.
Okay, but let's show you this part again here. This frozen shoulder is something totally different, ready to tone.
Oh,
See that? She actually feels that shouldn't cause a lot of pain.
It's an exaggerated reflection withdrawal response.
Look at her trunk again.
Or take a little on this one?
Yeah.
Okay, so exaggerated reflective withdrawal response on the right.
Okay, so she's got hyperalgesia. She's got pain sensitization. So there's mechanisms you need to figure out with that patient. Okay, and then you always also in your exam you always want to look at the skin. Make sure that you don't see these pseudomotor edema, vasomotor changes. These are scary when you see them because these are complex regional pain syndromes. They get really swollen like that. And I got to tell you, I'm completely 100% intimidated with complex regional pain syndromes. They're not easy to manage. Okay, they're like, if someone has that chief complaint, I usually have a talk with them and go, listen, you have to understand my success rate working with complex regional pain syndromes is pretty low. So if you're desperate and you want an effort, then let's work together. But I can't come into your case with a lot of confidence saying, no problem, we got this thing nailed in like a short period of time. They are really a very deep vicious cycle, especially when they start to get autoantibodies against their own autonomic tissue. But here you can see some of these vasomotor changes with complex regional pain syndrome. You can see just asymmetry and facial swelling. See that autonomic response just on one side of their face. And that intramedullary cell column that fires sympathetics does it on one side of the body. So here you can see the left intramedullary cell column is activating much higher on that one side. Okay, so those are some of the things you should think about when you're doing your exam. Okay, so these when you look at these pain syndromes, let's just focus more into these complex regional pain syndromes. That's when you see these this vasomotor responses, that tissue inflammation there, that swelling there, and that's just really that sympathetic activity firing like crazy and then causing some injury there. So listen, this guy didn't have a pain syndrome yet. He has left sides fired more. If he, let's say, goes and plays sports and has someone slam into his arm and maybe they tear some ligaments in his arm, that autonomic dysfunction that's already there combined with that injury then creates the pattern for complex regional pain syndrome. Okay? So you could have patients that you do an exam with, you do the pinwheel sensation, and they're like, oh my God, it's so much more on one side, and they like jump all over the place. How does it, do you still feel the pain? They're like, yeah, I still feel it. Then it goes on for a long period of time. Then you touch your skin, and there's different temperature activity one side or the other. You see those vasomotor changes. Even if they don't have a complex regional pain syndrome, you should let them know, like, do not do anything active and get injured because you're like really ready for this pattern to take place, especially if they also have things like immune tolerance issues or underlying autoimmunity. So technically these things are there and the injury amplifies and adds to it. Now this is a slide that shows the current International Association for the Study of Pain Clinical Diagnosis criteria for complex regional pain syndrome, which is continuing pain, which is disproportionate for the inciting event, right? So disproportional pain. And then they must report at least one symptom in 3 of the 4 following categories. Sensory, they have to have hyperalgesia or allodynia. They have to have vasomotor response, like the images that showed you, reports of temperature asymmetry and skin color change or skin, like that picture of the guy with the face on one side. Pseudomotor edema, again, that's swelling of the ligament, like the hand or feet you saw. Motor trophic, so reports of decreased range of motion and motor dysfunction, weakness, tremor, dystonia, any of these changes. So at least one symptom in the following 4 categories. And then second category, they must display at least one sign at the time of evaluation and 2 or more of the following. Sensory, evidence of hyperalgesia to pinprick or allodynia. So that we showed you examples of that. Evidence of temperature asymmetry. You can take a surface thermometer and just check one side or the other. And then pseudomotor edema asymmetry, and then decreased range of motion. There's no other diagnosis better that explains the signs and symptoms, right? So 2 or more of the following categories or one of the following, and also this disproportionate pain. Those are the diagnostic criteria. And then the other pain syndrome that you want to check out in your evaluation is fibromyalgia. And with fibromyalgia, I mean, they're basically like your chronic fatigue patients. They also have tiredness, sleep disorders, concentration problems, depression. Obviously just think of them as a mitochondria not working. Their bowels aren't moving. They may have shortness of breath, irritability, back pain, chronic pain throughout the body. And then, the standard approach is you palpate, and you palpate these fibromyalgia tender points. That's the key part for their established diagnosis. And then looking for these sensitive muscle sensitive points as 6 or more pain sites for a total of 9 possible sites. Moderate to severe problems or fatigue, and then these sensitive muscle points, sleep problems must have present for at least 3 months. If they fit these categories and you find these trigger points, then you have your diagnostic criteria for fibromyalgia. And then the characteristic features of fibromyalgia: widespread multi-site pain present for at least 3 months, fatigue, sleep disturbances, other symptoms such as cognitive disturbances, headaches, and so forth. Physical exam: widespread tenderness, absence of joint swelling or inflammation, so there's no like underlying inflammatory joint autoimmune response or something. And then normal ESR, normal CBC, normal thyroid testing, and so forth. So those are the things that are there to diagnose fibromyalgia. It's not really due to a disease. And there's lots of overlap between CFS patterns and chronic fatigue patterns. I mean, myalgic encephalitis and chronic fatigue patterns that are there. Tired, fatigue, exhaustion, sleep problems, and cognitive issues. Key thing is that fibromyalgia can be secondary to other diseases. Chronic fatigue syndrome has to be no other disease there. That's a disease of exclusion. And then with fibromyalgia, you just palpate those tender spots. So those are the key things with muscle studying. Those are the key things with the diagnosis of pain syndromes. Okay, so let's move on. Before we go on to the next section, which is mechanisms that increase opioid endorphins, let me tell you where we are so far. So what we went over in our evaluation was like, hey, we need to use pain scales sometimes. That can help us understand the amount of pain they have. So it's like between 0 to 10, 1 to 10, or mild, moderate, severe. You get some idea of what's happening with their pain. Different forms for that. Then you have different types of pain mechanisms. You have myofascial pain, you have myalgic pain, you have neuropathic pain, sclerotogenous pain, and then once you find out the type of pain they have, you look for amplifiers like histamine and hypoxia and catecholamines and glycosylated end products and insulin and those factors. And then you want to go in and do your exam, see if you see any signs of allodynia, hyperalgesia, and then see what kind of pain pattern, pain syndromes they have, if it's central or peripheral. And then once you do that, you kind of establish, okay, these are all the things that are causing pain. This is the severity of pain they have. And then you got to try to find things that work on the opposite spectrum. There's things that are in opioids that help decrease pain. So when you're actually trying to evaluate a pain patient, it's not just how much pain they have and what things are driving it, but also what things can counteract pain, which is where endorphins come in. So ultimately with pain, it's the balance between how many nociceptor amplifiers they have versus how many opioids they have. And then you look at their life. So things like physical exercise, laughter, healthy relationships, sex, touching, massage, volunteering, pursuits of passion, yoga, and meditation all raise endorphins. So like if they live alone, they're sedentary, they're not in a healthy relationship, they're not doing anything, they're not pursuing their passions, they really don't have any natural endorphin releases. That's not going to be good when it comes to chronic pain. So you can also see like when people get in a new relationship and they're like all excited about that, if they have a pain syndrome, their pain syndromes go down because they're getting circulating opioids that are happening. When people start getting into a regular exercise program, the pain mechanisms go down. So you might want to encourage people with chronic pain, find YouTube clips that are super funny, you watch them, try to find things that make you laugh, go get a massage. The fact that someone touches you and works out your trigger points and muscles can actually have very therapeutic effects on opioids that can really help conquer pain. Muscle massage can also help get myofascial trigger points that can be contributing to their pain. But these things all become really important. And then I should have added one other thing in here before I forgot, which is actually studies on it. It's having pets. So, probably not a fish, but like a dog that so happy to see you all the time and you get to hold them and they lick you and all that. That's going to help raise opioids as well. Okay. I'm not sure about cats, but for sure. No, I'm just joking. Okay. And then the role of brain function in pain. Okay, so let's talk about this also, because we talked about, you want to look at these descending inhibitory pathways, but you have to understand is that the brain, so let me put it differently. The sympathetic system is always firing, okay? It's always firing. And what stops it from firing all the time aggressively is pathways from the brain. So the brain has all these different autonomic centers, sympathetic, parasympathetic, they're all throughout the brain. There isn't one region, it's just a systemic response. But these regions of the brain fire and activate something called the hypothalamic spinal projections. And these hypothalamic spinal projections are what actually inhibit the sympathetic nervous system. So not only does your brain fire into the periaqueductal gray to dampen nociception to the spinal cord, but your brain, when it's healthy, activates the hypothalamic spinal tract projections that suppress the intermediolateral cell column, which calms down sympathetics. And when you have a person that has an unhealthy brain, then you can have these sympathetics that go like crazy. And that's where you can get someone who's got that vasomotor response and just on one side of their body, like that picture I showed you. That's immediately confirming that their hypothalamo-spinal tract projection on that side is not firing well. And that ipsilateral cortex is not functioning well. And then you want to understand why. Do they have a brain injury? Did they have something happen there? Like what is going on? And then that person with this increased sympathetic tone that's not being gated is a candidate for getting an injury and developing complex regional pain syndrome. You know, that's the ugly part of this. Now, there's also pathways in the brain that activate these sympathetic centers. So the top part of the brain stem, the midbrain, you have an area right next to the periductal gray, which is this area in here, this midbrain reticular formation that activates the sympathetic response as well. And it's linked to the colliculus where you have light and sound sensitivity. So a lot of times when people have light and sound sensitivity, they get an immediate sympathetic response. And also the vestibular system fires right into the sympathetic centers, because if you're falling, you have to increase your sympathetic system. Something quickly moves into your visual field, your tectum has to pick that up, and then you got to run away because it could be something attacking you. Something's very loud, it could be something about to injure you. So sudden sound, sudden movements, falling, they all activate the sympathetic centers. So you have some people that have like chronic pain dysautonomia because they have a vestibular disorder. They have dizziness and vertigo, and that dizziness and vertigo, the sense of falling all the time and moving all the time, activates their sympathetic centers. That activation of that chronic sympathetic centers leads to chronic pain syndromes, right? And those people then also have associated symptoms, like they can't handle light and sound. You know what you do with, like how to identify this? Someone comes in, they have chronic pain, and you go, do you have dizziness? They go, yeah. I go, okay. You go, look at my finger. And I look at your finger, you go, just keep your eye on it. You go, how'd you make you feel? Oh, it made me anxious. Then you're like, okay, that is a really overactive tectum, right? Or family members say, if I just come into the room and say, hey, honey, how are you doing? They just jump up, right? They have to like knock, slowly get to the room, that they can't handle these noises. Those are the sympathetic centers of the brain really close to the threshold. And those can lead to increased sympathetic tone, and those things can lead to pain syndromes. Here's like where you have people have vertigo, motion-induced nausea, these balance disorders, these pathways in the brain, the cerebellum, vestibular system fire right into the midbrain that activates the sympathetic chain. The heart rate goes up. They burn off glucose really quickly. This epinephrine, norepinephrine sensitizes nociceptors really aggressively. And here you can see vestibular sympathetic responses, and they just show when the vestibular system, these vestibular nuclei activated, it directly activates that intermedial lateral cell column and causes sympathetic pain. So there are some pain syndromes that really are due to unhealthy brain function. And it's not just like diet, that their brain, they have a mechanism not able to dampen their sympathetic responses. So when the brain cannot function very well, they can't dampen their sympathetic tone, and they get these increased sympathetic tones. So in summary, the brain really does two things. First, the brain, what we talked about earlier, it activates the ascending pain inhibitory pathways, actually activation of descending pathways for nociception, which impacts chronic pain. And at the same time, the brain has to activate and dampen sympathetic tone. And if it has inability to dampen the sympathetic centers of the system, the sympathetic tone goes up, they get increased catecholamines, they can even get neurogenic inflammation, then develop chronic pain syndromes. So people have past head injuries, neurodegeneration, neurodevelopmental disorders, just a hypoglycemic brain, just not getting glucose and fuel. They can really make these problems worse. So here's just a summary of those pathways here. Brain not working, they can't dampen the descending inhibitory pathways, and then, or here's another way to look at it. Activation of descending inhibitory pathways, excitation, inhibition of pain, spinal cord, that can decrease pain. If the brain is working well, activation of the spinal tract, excitation of inhibition of the middle cell column, decrease sympathetic tone, decrease pain. So the brain is involved with pain and sympathetic responses. This is a diagram I put together for you. It just goes into early brain degeneration to progressed. You can kind of read it on your own if you're interested in it, but it's very similar to the neurological assessment form, but just on a slide for some things. And then sleep is really critical for dampening pain and pain responses. And healthy sleep decreases sympathetic activity, shifts the body into anabolic metabolism and recovery, modulates inflammation and immune function, very critical for reducing pain. Unhealthy sleep increases sympathetic activity, disrupts cortisol rhythm, disrupts melatonin rhythms, increases inflammatory cytokines, and increases pain. And sleep as a clinical mechanism overlaps between fatigue and pain. So one of the things like we have to do when we have pain syndromes and fatigue syndromes to make sure that they actually sleep, okay? And then ultimately, when you're dealing with pain syndromes, you're going through your workup trying to figure out what kind of pain they have, what the amplifiers are, do they have centralization, do they have any autonomic issues, and then you're trying to figure out how much opioid release do they have in their life to counteract that. That gives you a clue when how to start a diet, nutrition, lifestyle approach, and then you also add in, how are they sleeping. So this is summarized here. So we're going to get into this when we get into treatment, but the three main mechanisms that impact pain perception are chemical mediators, so nociceptor amplifier sensitizers versus opioid endorphin releases, and then brain function, activation of brain ascending nociceptors in comparison to activation of brain descending inhibition of nociceptors, and then sleep, healthy deep sleep versus unhealthy sleep. So these three things is where we're going to really focus on in our evaluation and then eventually into our treatment protocol. And we'll get into that next. And that concludes the section on evaluation of pain. Thank you.